Hello everyone, my name is Ricard Navarro. I'm a cardiothoracic anesthesiologist in hospital clinic and also a member of the education subcommittee and the thoracic subcommittee of EACTA. First of all, I would like to thank the EACTA to give us this opportunity to participate in this initiative to create some specific tool for anesthesiologists in this COVID pandemic. And I would also like to introduce Felipe Unigarro, who is an anesthesiologist and colleague of mine here in hospital clinic, and he will introduce us the recommendations and interventions that have been adopted in our country to safely restart the surgical scheduling. None of the authors present any conflict of interest related with this presentation and lecture. Here I would like to introduce you some of the data that we have collected in our center. Hospital Clinic is a tertiary hospital situated in the middle of Barcelona, in the city center. From the 18th of February to the 14th of May, more than 8,700 visits in the emergency department were attended, and nearly 25% of them, meaning around 2,000 visits, were COVID-related. In the same period, we had 2,396 patients hospitalized for COVID. And you can see in here where they were hospitalized, and 264 of them were admitted in intensive care, 182 patients were admitted in intermediate care, and 1,625 patients were admitted in hospital. It's quite remarkable also that another hospital was open in a hotel, depending from our center, and this hotel admitted 523 patients, most of them who were quite with mild affection of COVID or who were recovering. When we look at the discharges, more than 2,364 patients were discharged, and we had 188 patients who died from COVID, meaning around 8% of mortality. Our mean stay in hospital was 12 days and 94. In these graphs, we can see the timeline of the infection rate and how many patients were there per day because of COVID-19. In the upper left part, we can see that the blue bars represent the total numbers of patients in hospital because of COVID-19. The red line are the daily admissions of patients diagnosed with COVID-19, and the green line are the hospital discharges of patients diagnosed with COVID-19. In here, we can see that the worst moment was between the 19th and 28th of March, where between 30 to 80 patients were admitted daily with a diagnosis of COVID-19. That caused that our center was close to be overwhelmed by the end of March. You can see that there was a peak of 597 patients in hospital because of COVID-19. Later, thanks to confinement measures, assistential pressure decreased by the end of March. In the lower left part, you can see the total number of patients in intensive care and intermediate care, reaching the maximum around 10 days later from the maximal admission moment, around the first week of April. In the graphic in the lower right part, you can see the prevalence of patients in hospital in conventional ward, being the peak also around end of March. It is also quite interesting to see what you can see in the upper right part. That's the prevalence of contagion of healthcare workers in our center, and that was also delayed around 7 to 10 days after the peak admission rate, reaching the maximum of 372 healthcare workers infected by the beginning of April. So, which is the current situation in Spain? We have here some information from the official website of our ministry, and you can see that to the moment, on the date of 9th of July, we have more than 252,000 cases confirmed in Spain. You can also see the information in Europe, having more than 2,700,000 cases, and the cases in the world, that at that moment are more than 11 million cases. The timeline we have seen in the previous slides from our center is consistent with what has happened in the rest of the country. You can see some more data from the Ministry of Health of Spain. The green bars represent the numbers of patients diagnosed by PCR with a diagnosis of more than 8,000 cases per day, nearly every day, between the 22nd and 31st of March, rapidly decreasing afterwards because of the confinement measures implementation. We can also see the diagnosed by serological tests in the yellow bars. and we can also see how cases continue to decrease, even if a significant number of cases is still being diagnosed by the beginning of July. A large seroprevalence macro study was performed, including more than 60,000 patients, and its data have just been published in Lancet in the beginning of July. We can see that the prevalence of 5%, in fact 5.2% of patients developed antibodies. This prevalence was largely variable between the different regions of Spain. Madrid and the surrounding provinces had the largest prevalence, whereas Balearic Islands, Canary Islands, Galicia and the south of Spain had the lowest prevalence. Some prevalence studies in healthcare workers have been done. On the left figure, we can see the total numbers of healthcare workers diagnosed of COVID-19 by the end of May in our country. Even if this information is a bit old, we have no newer updated information regarding infection in healthcare workers in Spain. We can see that much more women have been affected, mainly between 40 and 50 years old. In fact, in our center in Hospital Clinic, we performed a cross-sectional study that revealed a prevalence of infection of 11.2%. This is quite high, but it's lower than what it was really expected. More interestingly, a recent study poses the question of which is the main source of infection in the healthcare workers. In this study, just published in Lancet consisting of a cross-sectional study in Netherlands, they suggest that even if direct transmission in hospital cannot be ruled out, their data does not support widespread nosocomial transmission as the source of infection, playing the community-acquired infection a very important role. Obviously, that needs to be interpreted cautiously because that's in Netherlands in a very specific context, but it opens a new way of seeing infection through the healthcare workers. Then, bearing all this in mind, by mid-May, after a large decrease of infection rate was seen, this technical document was published. It was a multidisciplinary effort coordinated by the Ministry of Health of Spain to establish recommendations to safely restart scheduling of surgery during the transition period of COVID-19 pandemic. This document has been endorsed and written by members of the Spanish Association of Surgeons, a Spanish Society of Anesthesia, a Spanish Society of Preventive Medicine and Public Health, a Spanish Society of Infectious Diseases and Clinical Microbiology, and finally also Spanish Association of Surgical Nursing. Dr. Felipe Unigarro will now introduce you the main recommendations that have been gathered in this document.
Many thanks, Ricard, for that nice presentation. I'm going to keep going with a summary of the recommendations for planned surgical activity during the transition phase of the COVID-19 pandemic. So when we talk about resuming activity, there are a few recommendations that I will go through. I'll start with the general ones. It is important to create different circuits for COVID-19 and COVID-19 free patients. This includes different hospitalization areas, different lifts and corridors if that's possible, to avoid any risk of cross-contamination. During this transition phase, it will be recommended to create a surgical commission that will assess the surgical need of the patient, the availability of resources, and the COVID-19 status of the hospital at a given moment. And they will also coordinate and allocate independent physical circuits inside the surgical block for COVID-19 and COVID-19 free patients. This includes different theaters and different areas for recovery after the anesthesia. It is important also to organize health workers, if possible,